In the name of God, in this part we are discussing about the role of the calcium uh, and the homeostasis of the calcium and the role of the bone in the homeostasis of calcium. The normal level of calcium in the blood is about 9.4 milligram of deciliter, and calcium is one of the most important ion, which its hemostasis is very important for the body, because either hypercalcemia or hypocalcemia is very critical, specifically for the heart contraction, and sometimes it's and also for the nervous system. If the level of the calcium in the blood circulation will go further of 12, we call it hypercalcemia. And the net result of hypercalcemia is depression of the nervous system and coma. But if the level of the calcium in the blood will go lower than the 6, we call it as hypocalcemia, and the net result is excitation of the nervous system. But also in hypercalcemia, we have the arrest of the heart because of the arrhythmia. We have calcium in the blood circulation in three different forms. For about 41% of the calcium is binding to proteins, so this part is some reservoir of the calcium, and this cannot go and clear by the kidney through the GFR. But 9% of the calcium, it's not free, it's not in the ionized form, and it's not also attached to the protein, but it's attaching to some anion, the other anions like citrate and also like phosphate. So we call this the anion binding. They can clear by the kidney to the GFR. And 50% of the calcium is in the ionized form. This is the active or biologically active form of the calcium, because it can attach to the receptor, and it can be cleared also by the kidney. About 98.9% of the total calcium in the body is stored in the bone, but this is also similar for phosphate, but the rate is a little bit lower. It's about 85% of the total phosphate in the body is stored in the bone. So we want to see how the calcium is absorbing through the food by the intestinal and the gastrointestinal, and how it can go for reservation in the bone, and how is the role of the kidney by through clearation of the calcium. If the total calcium that enters through the normal food is about 50 milligram, we can see that in the feces and by feces, a large part of the calcium will be go outside of the body, about 12 milligram. But we have also some absorption of the calcium. It's 6 milligram. It can be absorbed, and it can enter the interstitial tissue and inside the body. But because some secretion, some gastrointestinal secretion that secreted to the gastrointestinal lumen and go to the feces, it contains also some calcium. About 3 milligram of the calcium can be secreted to the feces. So the feces is a major part for clearing calcium. But how about the urine? Urine is also important, although it just secretes and gets rid of the calcium about 3 milligram per kg. But because some of the hormones, specifically the parathyroid hormone, can have some effect on the kidney. This is an important organ for getting rid of the excess calcium of the body. But we have some calcium exchangeable, which is located in the bone. So it's about 8 milligram of the calcium. In the next slide, we are watching the role of the calcium reabsorption in the kidney. We can see that the ionized form of the calcium, or the or that part which is attached to the side citrate or also phosphate can be clearly filtered through the GFR, and 60% of this calcium is reabsorbed in the proximal part of the kidney, and just about 20% will be reabsorbed by thick ascending part of the kidney, and 10% is reabsorbing by distal part of the nephron. This normally it's ordinary part, and even your body is in the normal condition of the calcium level or higher or lower level, it doesn't matter. The kidney will act like this for three different conditions, but the determining part of the kidney which can determine and will be and act differently in hypocalcemia or in hypercalcemia. This is the end part or collecting ducts part of the kidney. If the person is in the normal diet of the calcium, normally 9% of the calcium will be reabsorbed from this part under the control of PTH hormone, and just 1% will be go through the urination. But in the condition of very low level of calcium in the body, all 10% of the calcium of the remaining calcium which reach this part will be reabsorbed. But in the hypercalcemia, all the 10% of the calcium will go through the urination. So everything in the calcium reabsorption is determined by the final part of the kidney. In hypocalcemia, normally we have some spasm in the muscle. The first muscle that we have see some spasm is carpopedal spasm. This is some indication of severe hypocalcemia, and after that severe seizure event or convulsion can be appear in the person. But in the next slide, we are just watching the different formation, different forming part of the bone. We know that bone is the most important reservoir for calcium. So most of the calcium which can be reserved, it's go to the bone. At first, we want to see which parts are located in the bone, and after that to see how it can be happening that calcium can be go to the bone. We know that the bone is containing organic matrix. Organic matrix normally 90% of it is composed of the collagen, and the remaining 10% is in the other non-collagen molecules like hyaluronic acid or the other proteins like that. But um, and we have between these organic and inorganic and the matrix of the bone, we have the calcium hydroxide apatite. So the calcium is in the crystal form. It can be appear between the collagens. So in the next slide, we can see a schematic diagram for collagen, for the location of collagen and calcium in the bone. We see that the fibers of the collagen, they are not in the monofiber form, but they are polymerized, and the collagen in the bone is after polymerization, we have the collagen. And the crystals of the hydroxyapatite are attaching to this collagen. This form is very look like as that's something that we use, the iron that we use in the structure of the for building the houses, and we call them beton arme. Beton arme means very strong. Army is a French word which is derived from the army. Beton army means a very strong beton. Beton, they are if the fiber of the collagens are look like the iron in the structure, in the building structure, they are very resistant to tension and to stretch. But the hydroxyapatite calcium, they look like some stones which are between the ions in the structure of the building. And these calciums, these hydroxyapatite calciums, are very resistant to pressure. So in the bone, we have a structure which are not only very resistant to pressure, but also are very resistant to stretch. But hydroxyapatite does not precipitate in other organs, just they are precipitating in the bone. But also sometimes in the other organs beside bone, we have the situation for precipitation of and for formation of hydroxyapatite. Why the hydroxyapatite crystals are just appear in the bone, not in any other organs? Because in any other organs, we have just an inhibitor of pyrophosphate, uh, an inhibitor of hydroxyapatite formation. We call this inhibitor as pyrophosphate. So the pyrophosphate is neutralized in the bone, although it's also formed in the bone, but the pyrophosphate will be neutralized in the bone. So I'm sorry. So we have the precipitation of hydroxyapatite in the bone, but in other organs, because of the location of this inhibitor, pyrophosphate, the precipitation and formation of hydroxyapatite crystals will not appear. But sometimes there are uh, three different proteins for forming or inhibiting the action of hydroxyapatite, and sometimes they are not working and some diseases will appear. But how the first bone is calcification. At first, we know that we have three different cells in the bone: osteoblasts and osteocytes. They are the bone, the cells responsible for bone formation, and osteoclasts. They are the cells responsible for bone resorption, because they are a kind of osteoclast. Osteoclasts are a kind of macrophages. At first, the osteoblasts are secreting collagen and the matrix, or a ground substances, which is the matrix of the bone. And after that, the collagens will be polymerized, and we call the polymerized collagen in the substances in the matrix as the osteoid. Osteoid is very softer than the bone, and this is something exactly look like something we have in the cartilage. But the differences between the cartilage and the bone is the formation of hydroxyapatite crystals inside of the osteoid. So the first formation of the bone, we call it osteoid. Osteoid is the collagen without having any hydroxyapatite crystals. But after attaching the hydroxyapatite to the collagens, we call it as bone. We must know that the calcium in the bone is in the two forms. First form is amorphous compounds. Amorphous compounds means they are not in the crystallized form. So before going to the crystallization formation of the hydroxyapatite, the calcium just will trap, and it will just form some amorphous compounds. These amorphous compounds are very flexible, so it can be transit easily between the blood and the inside of the bone. But when the bone is formed, when the calcium is forming the crystallization of hydroxyapatite, they cannot the calcium inside of the crystallized hydroxyapatite cannot transit easily and go to the blood circulation. Something must destroy this crystallization formation, and this is the acid. Just acid can penetrate to the crystallized hydroxyapatite and change it. So in the next slide, we are see the remodeling of the bone. What does it mean, the remodeling of the bone remodeling? Like any other living organ, the bone is also remodeled. It means that some old part will be destroyed and the new bone formation exists even during the very elderly person. In the elderly person, the remodeling is happening. For remodeling, at first the osteoclast, the kind of macrophages, will be activated and it will attach to some part of the bone, and after that this is under the control of PTH. But PTH in this part is acting like in the a catabolic action of itself, and it needs at least 3 weeks, near 21, 21 days for absorbing some part of the bone. Just after that, a hole will be will be appear on the surface of the bone. And after appearing this bone, this hole, the osteoblast will be activated. And if they will have the necessary things, I mean the collagen and also the calcium, it can refill this hole and a new bone will be appeared. This is also under the control of PTH. This is the anabolic action of the PTH, and it needs near 3 months for filling the hole inside of the bone. But we must to know that how osteoclast can act and absorb some part of the bone. In the next slide, see a osteoclast which is attached to the surface of the bone. We know that the composition of the bone mostly is protein because of the collagen fibers that are consist of the proteins. So this is very easy for osteoclast to destroy proteins by protease, some enzyme which can lyses the proteins. But how about the hydroxyapatite crystals? For hydroxyapatite crystals, just acid can destroy them. So inside of the osteoclast, there are a hydrogen pump which insert little by little the acid into the surface of the bone, and because of the low pH of this in the surface of the bone, the hydroxyapatite will be also destroyed and the calcium will be released. So this is the same. The remodeling, sometimes remodeling is not happening just for renewing the bone. Sometimes PTH is acting as the catabolic action because our body is in the low level of the calcium. So if our body needs calcium, PTH will be activated. But at first, it will not go straight to the middle of the bone and lyses the crystallize of hydroxyapatite, because we know that low level of the calcium is very dangerous and sometimes it will lead to seizures, to convulsions. So what is the reaction, immediate reaction of the body, because we need immediately to compensate the low level of the calcium. We have previously talked about the amorphous kind of the calcium. This kind of the calcium is very flexible, is very reachable, and it's not located as the crystallized of uh, hydroxyapatite inside of the bone, but it's located very close to the surface of the cell of the bone, and at first under the control of the PTH, these calciums will go to the blood and compensate the low level of the calcium. But if the hypocalcemia will persist for a long time, for example, during pregnancy and during the pregnancy, if the pregnant woman will go for different pregnancies which are very close to each other, for example, not the differences between pregnancies, these persons, because the fetus and the embryo needs a high level of the calcium for bone formation, for any other organic formation. And because of that, the fetus have some calcium pump which absorb any little calcium from the blood circulation of the mother. And because of that, if the nutrition of the in the if the nutrition status of the mother will not be okay, what will happen? The mother will lose some parts of the calcium of her bone, and this is the catabolic action of the PTH. So at first, PTH will go to the amorphous calcium inside on the surface of the bone, and after that, if the hypocalcemia will exist for longer time, what will happen? The inside of the bone will be destroyed, and this is something that we call it as osteoporosis. Osteoporosis means that the person is losing some part of the inside of the bone without any formation, any renewal. But we must consider that PTH is very important hormone for the calcium homeostasis in the body. But we see that at first for remodeling, the osteoclast is activated by PTH. We must consider that osteoclasts don't have any receptors for PTH, so PTH cannot directly activate osteoclast. The only cells inside of the bone which have uh, the receptor for PTH, they are osteoblasts. So what will happen when the PTH wants to have to act when PTH wants to act as its catabolic action? At first, PTH go to and attach to the receptors on the osteoblast, and after that, some cross-talking between osteoblast and osteoclast is happening through the formation of some cytokines. At least two important cytokines is appeared which activate from osteoblasts, which activate osteoclasts. The first one is rank ligand, rank L. It means that when we are talking about ligand, it means that there must be a receptor for that ligand. Ligand is a very general name for any component which can act through a receptor. So it means that there is a ligand, which is the name of the ligand is rank, and this ligand has a receptor which is located on the osteoclast. So ligand of rank will go and attach to the receptors of rank, which is located on the osteoclast, and after that, the osteoclast will be activated by ligand of rank. The other component which can activate osteoclast are MCSF, monocyte colony stimulating factor. These two factors will activate osteoclast. But after 3 weeks, the activation of osteoclast must be finished, and after that, osteoblast normally will go and refill the hole which is created by osteoclast in the bone. But how it will happen? Why osteoclast will not continue after 3 weeks its work anymore? Because after 3 weeks, although the osteoblast is also producing ligand of rank, but we must consider also the other name of ligand of rank is ligand of OPG. After 3 weeks, the osteoblast will create and produce another factor which is OPG. OPG is very similar to the receptor of ligand of rank, which is located on the osteoclast. So, because of the producing OPG, ligand of OPG will be attached to this OPG, and it will not go and activate its receptor on the osteoclast anymore. So, the action of the osteoclast will be terminated. In the next slide, we see the composition of a bone. We know that each hole of the bone, which is renewal, we call it osteon. So after creating a hole on the surface of the bone by osteoclast, the osteoblast will go and it try to form the new bone. But but they will renew it by circular, which is forming from outside and going to the inside. So it starts to renew the bone formation from outside by some circles and going to inside. In the inside and in the middle, we have some vital part of the bone. They are nerve, blood vessels. Normally, the osteoblast will not go and tighten the last circle, so no harm will happen for the bone and for vessels and nerve. But sometimes, specifically in the cancers of the bone, we know that the cell of the cancers, the cancerous cells, they cannot understand and obey any rule of the body, and because of that, sometimes or most of the time in the cancerous cells, the last circle will be very tight, and because of that, the bone, we have some necrosis in the bone cells, and also it's very painful. The cancers of the bone is very painful because they have some pressure on the nerve of the bone. Okay, this is the first part for calcium, and if you have any questions, please ask me, and I will be very glad to answer your questions.